Thank you very much for having me today. I'm Professor Imam, one of the trauma and upper limb consultant based in London. I am a professor of digital health and I'm leading research in Ashford and St. Peter's Trust as well as the Smart Health Center in London. I'm going to talk about a very important topic, wrist instability, a game-changing injury for our patients over the next few minutes as part of CCOT educational series. We cover this topic in our podcast and there are other topics there as well. We're going to talk about the anatomy, the classification. We're talking about the most important, commonest instability, which is scapholunate instability, as well as other carpal instabilities, which is a huge topic, and there are topics allocated for that topic. There are books, allocated for this topic only, including clinical assessment, imaging, surgical principles, and rehab, and the debates associated. So, understanding wrist anatomy is essential before addressing instability because the wrist is a complex linkage system involving 8 carpal bones, multiple ligaments, as well as other structures. And the carpal bones are arranged in 2 rows. Proximal row, the scaphoid, which bridges both rows, the most commonly fractured carpal bone, a nasty bone to fix and heal, with oblique orientation, which means that it flexes with radial deviation. While you have the lunate, which has a central rule in force transmission, contributing to subjected to 60 to 80% of axial load, and articulate with the radius, capitate, triquetrum, with capitate, and then you have the triquetrum, which articulates with the hamate through the helicoid joint. You have the pisiform, which is a sesamoid in the FCU tendon and doesn't contribute to primary stability. Then we have the distal row formed of trapezium, trapezoid, capitate, hamate, which is tightly connected and always move as one unit. The proximal row has no muscle or tendon attachment, which means its position is entirely determined by the forces transmitted through it from the ligaments, the geometry of the bones, and the load applied as well. And this is why ligament injury leads directly to carpal instability. The proximal row is sometimes described as the floating segment. When the scapholunate ligament ruptures, the scaphoid tends to flex because it falls into flexion, and the lunate extends, and that's what we call a dizzy pattern. So, then what about the wrist ligaments? They are classified either intrinsic, so between carpal bones, or extrinsic, from the radius ulna to the carpal bones. The intrinsic ligaments include the scapholunate ligament, which is a very important strong ligament, C-shaped in structure, with the dorsal portion is the strongest and most critical for stability. The palmar portion is strong, and the proximal fibrocartilaginous part, which is the third part, which is the weakest. We have the lunotriquetral ligament, which also is shaped with palmar portion the strongest here. So, and we have the intercarpal ligaments of the distal row, which is very strong and rarely injured in isolation, and that's why it moves in as a single unit. Volarly, we have the extrinsic ligament, and this includes the radius scaphocapitate. We will refer to it as the RSC later in this presentation, which comes from the radius styloid, spans the waist of the scaphoid, and it is an important secondary scapholunate stabilizer. We have also the long radiolunate ligament, which connects the radius to the lunate and limit lunate extension. We have the short radiolunate, which is the primary stabilizer of volarly as well. It's important to mention that between the RSC and the LRL, there is a space called the space of Poiré, which is a naturally weak area through which perilunate dislocation occurs. So, what about the triangular fibrocartilage, a commonly injured structure that we see in our clinics? A lot of patients with ulnar-sided wrist pain present with this injury. So the TFCC is the primary stabilizer of the DRUJ, distal radio-ulnar joint, and the ulnocarpal joint. And Palmer in 1989 describes the components into an articular disc, a meniscus, a palmar and dorsal radio-ulnar ligament, as well as an ulnocarpal ligament, which is divided into two. And they have classified as well tears into type 1A, which is central perforation, B, which is ulnar avulsion, C, which is distal avulsion, D, which is radial avulsion, and class 2, which is degenerative. So, the articular disc of the triangular fibrocartilage extends from the sigmoid notch of the radius to the base of the ulnar styloid and transmits 20% of axial load. You have the palmar and the dorsal radio-ulnar joint. The palmar limits dorsal subluxation of distal ulna, especially in pronation, while the dorsal radio-ulnar ligament limits volar subluxation in supination. And you can see them clearly in this diagram.
Here's what I found.
So, there are multiple classification systems. The most commonly used is the Mayo classification, based on anatomical location rather than mechanism. Coney later on expanded that into 4 categories. In the Mayo classification, we hear these terms all the time: SED, SEND, CES, CIC, and the CIA. So CID means that carpal instability is associative. So there is instability within the same carpal row, like scapholunate dissociation, lunotriquetral dissociation, which are the most commonly typed. In carpal instability non-dissociative, there is an instability between rows, like between the radiocarpal, DRUJ, or midcarpal instability. If it is a mix between 1 and 2, we term it the carpal instability complex or combination. There is a combination of, like example, perilunate dislocation, where there is a disruption of the scapholunate ligament, and then you have radiocarpal disruption. It is high energy, and that usually happens in high energy trauma. And then we have the adaptive type, which is the secondary type, like having a malunited distal radius, congenital laxity, rheumatoid arthritis patients. A teaching point here: if you have a scapholunate disruption with lunate dislocation, that's a combination. And also an important bit that I'd like to check when I'm classifying these is it static or dynamic? Because static is visible on neutral X-rays where it is shown all the time, while dynamic only happens on dynamic assessment. And you can see this 4 classification clearly demonstrated here in this diagram. And then you can see the different grades on the and mechanisms that happen there. Dizzy versus Vizzy describes the posture of the lunate on the lateral radiograph. Normally, radius lunate capitate and third metacarpal should be collinear, with scapholunate angle of 45 to 60 degrees and radiolunate angle 0 to plus minus 10 degrees. In dizzy, lunate dorsiflexed, and the radiolunate angle is more than 15, and scapholunate angle is more than 70. And dizzy is usually common, happens with scapholunate tear. Remember the mnemonic: dizzy, lunate tilts dorsally. In Vizzy, the lunate is volar. It is important to know that this classification, dizzy versus Vizzy, is mainly describing the posture. They don't tell the cause. A dizzy pattern can be seen in scapholunate tear, scaphoid fracture non-union, or also known as SLAC, perilunate dislocation, and rarely after distal radius malunion. And whenever you have these patients, we measure the carpal height ratio. You can see Terry Thomas sign and signature sign, which will come to these. And as you can see here, normally the radius, lunate, capitate, and third metacarpal collinear straight line with scapholunate angle of 45 to 60 degrees and radio lunate angle from 0 to plus or minus 10. Let's start with the most common instability, which is scapholunate instability, and it is the most clinically significant instability that we see in our practices. And usually these patients will describe the same mechanism of injury with forced dorsiflexion, ulnar deviation, and pronation, which happens when you land on outstretched hand, fouche. The scaphoid flexes and pronates, while the lunate extends and supinates, and so that puts the scapholunate ligament under maximum tension. And the tear progresses from the dorsal side to the space of Poirier, and which will open, and then you have complete scapholunate disruption, and then progresses into the Mayfield stages of perilunate injury, which we'll cover later on. There are secondary stabilizers which is trying to stop that from happening. That includes the radioscaphocapitate ligaments, the DRC, the DIC ligament. When intact, the scapholunate ligament is torn, we have what we see as dynamic instability. But when all fails, we see static instability. And then you have progression to a SLAC rest, which we'll cover it later on. So what is a SLAC rest? This was described by Watson and Palais in 1984. It is 4 stages with progressive involvement. You have radiolunate joints paired until grade 4, and this has an indication for our treatment option, because usually you can still PRC, proximal row carpectomy, can be used because of that. So in stage 1 and 2 we can do styloidectomy plus or minus proximal, and do proximal row carpectomy. In stage 3, 4 corner fusion can be an option, and stage 4 can be total wrist fusion. It was mentioning scaphoid non-union advanced collapse or SNAC rest, which is similar pattern from untreated scaphoid union. In stage 3, we usually also 4 corner fusion is a very good option. Here, as you can see in the diagram, the tear progression through dorsal space and then complete disruption, and then followed by the Mayfield classification of perilunate dislocation. And these are MRI images and X-ray demonstration of the ligaments and where you can see them. Another classification and radiographic assessment range also 4 grades, with grade 1 normal, almost, grade 2 is dynamic, grade 3 is static instability, and grade 4 is a SLAC rest. And seeing them, this is actually, seeing this can dictate the treatment. And MR arthrogram with gadolinium or saline injected into the radiocarpal joint has a high sensitivity of 76 to 100% for full thickness scapholunate tear, less reliable for partial tears. And also recent evidence says that 3 Tesla MRIs superior to 1.5 Tesla MRIs for small tears. Arthroscopy gold standard because it allows direct visualization and treatment, and we have many arthroscopic classifications there. Treatment scapholunate joint is debatable. There are different options, different schools, different techniques, and ranging from non-operative to operative options, including Pronelli, where you use 3 ligament tenodesis, new internal braces, and others. But in grade 4, possibly if it's salvage, and we can achieve 80% of good and of good or excellent outcome with acute repair. Outcome worsens with delay. And you can see the different classifications here. When you see these patients, you see the teratoma sign. You have to measure the angles. It is an injury that shouldn't be missed because it can be a life-changing injury. This is a summary of the treatment algorithm, and it is very debatable. We have newer options like internal braces, anchors, and this has also helped significantly in helping our patients. Historically, there were different options described, and actually a lot of these are still followed now in our practices. So beyond scapholunate instability, we have other instabilities. This ranges from lunotriquetral instability, which is the second most common, midcarpal instability, distal radio-ulnar joint instability, and obviously the perilunate dislocation. Lunotriquetral instability is the second most common carpal instability. It's frequently missed or delayed in diagnosis, and it produces, as we said, a visit pattern where the lunate goes volarly when complete. The lunotriquetral ligament is a C-shaped ligament with the palmar motion, unlike the scapholunate ligament, is strongest, and stabilized secondary by the ulnocarpal ligament, the dorsal radiocarpal ligament, the dorsal intercarpal ligament, and also for an outstretched hand, but the rest here will be an extension and radial deviation with pronation. Also, ulnar impaction syndrome causes progressive lunotriquetral wear and can cause tears and can occur in isolation or as part of stage 3 May field. And these patients, you'll have tenderness on the lunotriquetral joint, and the Reagan palutment test, which we'll cover, will show it. X-rays and having visi pattern with radiolunate angle less than -15, and IMR arthrogram is actually the treatment, is actually the investigation of choice. Different options has been described, and this is the radiographic findings, and you can see the ligament there on the diagram and the cadaveric dissection. We wrote our technical note of producing an artificial ligament augmentation and repair of the lunotriquetral ligament, which you can access there. Another type of instability is the midcarpal instability, which is a poorly understood entity characterized by instability at the midcarpal joint, so between the proximal and distal carpal rows. It is sort of a carpal instability non-dissociative pattern. The proximal row moves smoothly from a visi-like position in the radial deviation to a dizzy-like position in ulnar deviation, which is the normal column theory of normal motion. We're talking about normal biomechanics of normal rests. In midcarpal instability, the proximal row actually remains stuck in visi during rest movement, and then abruptly catches up into neutral or dizzy position when ulnar deviation. And this is what we call the catch-up clunk. And the causes here can be extrinsic, which is the most common cause, where there is generalized ligamentous laxity, often idiopathic in young women with no specific injury. And intrinsic disruption of the triquetrohamate or the arcuate, or what we call the deltoid ligament, which might be following trauma. Usually young women between 20 to 40, and this catch-up clunk reproducible by the patient. And these patients will have diffuse or radial rest pain, and definitely pain with weight bearing through the rest. But you have to exclude other causes, because your differential diagnosis here include TFCC tears, scapholunate instability, snapping extensor carpi ulnaris tendon, extensor ulnaris tendon subluxation. Usually they respond to hand therapy, including proprioception training and splinting in mid-mild extension, and 70% would improve without surgery. Surgical option here will include dorsal capsulorrhoesis and dorsal radiocarpal ligament advancement plication, soft tissue reconstruction, or triquetrohamate arthrodesis in selected cases. And I always hear counsel patients that surgery results are unpredictable. What about the perilunate dislocation? So in perilunate dislocation, what happens is the capitate dislocates dorsally, lunate stays in place, relunate dislocate follow by going out palmarly into the carpal tunnel. And Mayfield has described the greater arc, which is fracture through the carpal bones, and the lesser arc, which is purely ligamentous. You can see on PA X-rays with overlapping bone, disturbed glular arcs, and on the lateral side you see a piece of bicep, and definitely CT is needed here. This is an emergency. This is one of the few cases in orthopedics that you have to take them as in the middle of the night. To do open surgery, you can use volar, dorsal, or both approaches, scapholunate and lunotriquetral repair, K-wires, carpal tunnel release, and sometimes ORIF of the scaphoid if broken. If done at the right times, 80% of patients are happy. A vascular necrosis of the lunate happens in around 10%. Unfortunately, it is missed in 1/4 of ED presentation. Any sprained wrist after high energy trauma definitely needs careful PA and lateral view. In the perilunate dislocation, so what is the difference between perilunate dislocations versus lunate dislocation? In perilunate dislocation, the capitate and the rest of the hand dislocate dorsally relative to the lunate, but the lunate actually stay in the fossa. But in lunate dislocations, the lunate is forced out of the fossa, going volarly into the carpal tunnel, with the capitate relocating it to the lunate fossa. And Mayfield progressive perinural stability described in the 80s classifies stage 1 with scapholunate tears, stage 2 the capitate dislocates, stage 3 the lunotriquetral ligament tears and entire proximal row except lunate is dislocated, and stage 4 the lunate dislocates volarly and capitates it into the lunate fossa. And you can see this here in these diagrams. So, systematic approach to clinically assess these patients, starting with history, inspection, palpation, motion, special test, and then imaging protocol. Different tests has been described. We'll go through them one by one. And then you do x-rays, PA neutral, I do PA neutral, PA clenched fist, PA radial and ulnar deviation, lateral neutral, lateral extension, and always compare contralateral. One test is important, the Regan palutment test. In the test on the affected wrist, you stabilize the lunate, move the triquetrum dorsally and palmarly, and look for pain tenderness, and repeat on the other side. A positive test means lunotriquetral ligament injury. And this is the Regan palutment test here, as I said. With the Kleiman chair test, you keep the wrist and forearm in neutral, stabilize the radiolunate joint in one hand, and with the other hand load the triquetrum and pisiform in the dorsal volar AP plane to create shear stress across the lunotriquetral ligament. If there is a clunk, that is a positive test. In the midcarpal shift test, you assess the palmar midcarpal instability, position the wrist in a neutral flexion extension with slight radial deviation, and the forearm has to be pronated. And then I apply palmar pressure over the distal carpal row or the capitate specifically, translating the distal row palmarly. While maintaining this, you can do ulnar deviation. A positive test here can cause a clunk, and that is actually a sign of generalized laxity. Piano key sign for distal radioulnar joint where the arm is pronation and the wrist in neutral. Stabilize the wrist and press the ulnar dorsal to palmar, like pressing a piano key, which can indicate that. TFCC compression test, you assess the triangular fibrocartilage compressed, rest in ulnar deviation, apply axial load through the wrist while gently rotating the forearm or the wrist, and a positive test can indicate a TFCC pathology. Radiographic assessment is standard and would involve a lot of drawing. M-arthrogram, arthroscopy are excellent tools in identifying and managing these. So the surgical management here requires correct patient selection, appropriate timing. You have to do the correct procedure if you can. Meticulous technique and warn patients we can have unexpected outcomes. Arthroscopic wrist surgery is becoming more popular. Portals are named by their positions relative to the extensor compartment, and you can see the different portals there. And it is commonly done, and with patients with negative radiographs, it is a very good technique. Dorsal approaches is still commonly used and mainly done for the different procedures we've described. Rehabilitation protocol varies by the procedure but follows 3 general phases. Phase 1, which is the protection. Phase 2, which is the mobilization, and that usually starts 6 to 12 weeks from injury. And phase 3, which is the strengthening, and that starts from 12 to 24 weeks. And that is variable among different procedures we use. Stiffness is the single most common complaint after any wrist ligament surgery, because we do prolonged immobilization still. There is post-operative scarring, complex regional pain syndrome, and for me, it is all about hand therapy referral early, removal splintage from week 6, and start physio and reconditioning. So, I hope I've covered as much as I can of such a very complex and long topic. We've covered the anatomy, we've covered the classification, how to diagnose, treatments, and rehabilitation, which I think rehabilitation is almost as high as 50% of treatment success. My final message to you: any sprained wrist lasting more than 6 weeks, investigate with stress X-ray, MR arthrogram, and the missed scapholunate ligament tear today is a SLAC salvage wrist in 10 years' time. Remember that. Thank you very much, and I wish you the best of luck in the exam.